Welcome to the deep dive. We are cutting through the noise today to get right to the most vital focused knowledge from our source material. Our mission is, well, surgical precision. Literally.
Literally.
Yeah, we're diving into a really specialized piece of equipment used in GI endoscopy, the Overtube, and more than that, what it tells us about managing risk. Our insights today are pulled from an excellent technical source. We're looking at excerpts from Dr. G.S. Raju's YouTube series.
That's right.
Specifically, Lesson 12 on foreign body retrieval. The core idea is, if you need to repeatedly access a delicate internal pathway, say, to remove something that's lodged,
Yeah.
you need a protected corridor.
And that corridor is the overtube. Exactly.
Right.
This whole thing is about a fundamental trade-off in procedural medicine.
That trade-off.
Yeah, you're investing significant technical effort before the procedure even starts, all to guarantee safety during it.
Yeah.
The overtube system, it's not simple, but its complexity is completely justified.
It's a shield.
It is. A dedicated shield designed to protect the patient's delicate esophagus and pharynx from the trauma of just moving instruments back and forth.
Okay, so let's unpack this crucial piece of safety gear. It sounds like a single tube, but the source material confirms it's a multi-component system.
It is.
So before we even get into the assembly, what are the core parts we're looking at?
Right, so it's a dual tube system, plus a couple of necessary caps. First, you have the soft inner tube.
Okay, the soft one.
And that sits inside a slightly stiffer outer tube. The outer tube is really the one that's going to be the eventual protector. The inner tube is more about stabilizing things during the initial insertion.
And what about the caps?
So you have two caps, and the timing of when you use them is critical. You start with what's called the inner tube air seal cap.
The air seal.
Yeah, and its role is straightforward but absolutely essential. It stops air from escaping. If air escapes, you lose insufflation. Your visual field it collapses.
And the procedure grinds to a halt.
Exactly. The second cap is the insufflation cap, and you only use that one later, after you've pulled the inner tube out. And make sure you can still get air into the stomach through the outer tube that's left behind.
I'm just struck by how quickly the complexity builds. I mean, this isn't just one scope. It's two nested tubes, specific air seals. If the whole goal is protection, why the two-tube assembly? Why not just one rigid sleeve?
It's a tactical maneuver. Really, it's all about ensuring a proper fit and smooth movement. The inner tube gives you a necessary surface for lubrication against the outer tube, and it gives the endoscope a nice tight fit when you're first putting it all together.
No.
So when you prepare this whole assembly, there are these 4 very precise steps, and they are all about making sure you get maximum glide and just minimal friction.
Okay, let's walk through that tactical setup. What's the preparation checklist to load the overtube onto the endoscope? And what's the one step you absolutely cannot skip?
The whole prep, honestly, it focuses almost entirely on lubrication. That's what makes the whole passage possible.
Okay, step 1.
So first, you actually remove the inner tube.
You take it out. That seems a little counterintuitive.
It does, but it lets you do step 2 properly, which is to generously lubricate both the inner tube and the outer tube. And the source materials, they really stress this, and generous lubrication is very important.
So we're not talking a small dab.
No, this is a full coating. You need those two surfaces to just glide against each other.
Okay, so they're lubricated. Then what?
Step 3, you insert the inner tube back into the outer tube until it is, and the term used is, almost snug.
Almost snug.
And then finally, step 4, you insert the endoscope into that inner tube until the tip comes out the other side. That sequence is designed to maximize that lubrication layer between all the moving parts.
So we've got this generously lubricated, slightly bigger and stiffer unit ready to go.
Oh.
This feels like where the safety stakes get raised, like, dramatically. Because this isn't a standard flexible scope. What extra physical precautions are mandatory before you even attempt insertion?
The first, and most critical, is realizing that the pathway needs to be manually straightened.
Straightened? How?
Well, because the device is less flexible, you have to ask the nurse or the anesthetist to actively provide a jaw thrust. Or to just extend the jaw.
To open everything up.
Right. That maneuver helps open the upper airway, and it aligns the oropharynx, straight down into the esophagus. It basically turns a curved path into a straight shot for the device.
And what about something like a bite block? I imagine any obstruction is a huge hazard.
It is. And this is the safety step that's so easily overlooked. The whole assembled device, it's just too big to fit through a standard bite block.
So you can't use it?
You can't. The bite block must be removed entirely before you start. If you try to force it, you risk immediate trauma.
Wow.
And, tying back to lubrication for a second, You lubricate the tip of the assembly for the patient, but you explicitly do not lubricate your own hands.
You need a firm grip.
You need a firm grip on this larger, stiffer device to make sure that passage is gentle.
It really sounds like a delicate surgical dance. You're balancing this need for a straight, more rigid path with the absolute necessity of being gentle to prevent, what, lacerations of the hyperpharynx?
Lacerations of the hyperpharynx of the upper esophageal sphincter?
That's right.
Absolutely. The margin for error here is tiny and trauma is serious. You're navigating one of the most sensitive parts of the GI tract with a relatively bulky piece of equipment.
So every single preparation step is designed to mitigate that one moment of risk.
During insertion, yes.
Okay, so once that difficult initial insertion is done and the whole assembly is gently navigated into the stomach, now we get to the core of it, the in and out strategy. How does that outer tube become the permanent protected pathway?
This is the moment the overtube really earns its name.
Okay.
Once the entire assembly is sitting gently in the stomach, you do the critical separation. You remove the endoscope and the inner tube together.
Leaving the outer tube behind.
Exactly. That leaves the stiffer outer tube fixed in place, running all the way from the mouth down into the stomach.
But now you've got a big opening. What about the air seal?
Right, so now that the inner tube's gone, you immediately place that specialized insufflation cap over the outer tube. That maintains your air pressure. And now that outer tube is your permanent conduit.
Your highway.
Your highway. You can reinsert the endoscope repeatedly in and out, passing it through that protective sleeve without ever touching the delicate esophageal or pharyngeal tissue again.
That is the core insight. The system is essentially buffering the patient's own anatomy from the procedure itself.
Yes.
So beyond retrieving foreign bodies, what other kinds of procedures really benefit from this, from being able to rapidly pass the scope back and forth?
Any procedure that just demands time and multiple movements. So yeah, foreign body retrieval, rapid stomach evacuation, sure. But where this really shines is in prolonged advanced therapeutic procedures.
Like what?
Well, think about techniques like endoscopic submucosal dissection or endoscopic mucosal resection. These require all kinds of specialized tools and repeated trips in and out with different instruments.
And without the overtube, every one of those trips would be scraping along the pharynx.
Every single one. The outer tube ensures that a 2-hour procedure doesn't result in 2 hours of physical trauma to the throat.
It's all about mitigating that cumulative risk. So are all overtubes the same, or do physicians select different lengths depending on where they need to work?
Oh, they absolutely vary. It's based on the target area. You have shorter overtubes that are really just meant to stabilize the pathway through the esophagus.
Okay.
But if your procedure, say, removing a complex foreign body, requires guaranteed protection all the way down into the stomach, you need a longer overtube to reach that far and stay fixed.
And there's one last kind of advanced safety consideration that the source material brings up, specifically about intubated patients.
Right. This is a big one. If the patient is already intubated, the physician should request that the anesthesiologist paralyze the patient temporarily.
Temporarily paralyze them just to pass this tube. That really highlights the intensity of the barrier we're talking about.
Yeah.
Why is that necessary?
It goes right back to the anatomy. That upper esophageal sphincter, it's a muscular ring.
Right.
And when you're dealing with a stiffer device like this, if that muscle is tight, the risk of perforation or a bad laceration just goes up dramatically.
So by paralyzing the patient,
The sphincter completely relaxes, it just opens up, and it allows the overtube to pass down easily and safely. It minimizes the technical difficulty and, the risk of a catastrophic injury.
wow. So the protective measures really run the gamut, from simple things like more lubricant and getting staff to help with the jaw thrust, all the way up to temporarily overriding the body's natural muscle control just for a smooth passage. It's an incredible level of high-stakes planning.
It's really the pinnacle of procedural planning.
Yeah.
The overtube adds a logistical hurdle to the setup, right? We've just detailed 4 complex steps.
Yeah.
But that single moment of difficulty buys the surgical team hours of protection and stability. It simplifies the actual intervention. It's a calculated trade-off of initial complexity for long-term safety.
So what does this whole deep dive mean for you, the listener? When we examine medical technology, we learn that the most effective tools, even something that seems as simple as a plastic tube, are backed by intensely precise, detailed protocols.
Yes.
Every single decision, from how much lubricant to use, to taking out the bite block, to temporarily paralyzing the patient, is engineered entirely around mitigating risks that the patient might never even know existed. That intense focus on protocol, That is the difference between a successful procedure and a preventable injury.
Absolutely. And it raises an important question for you to think about. If a relatively standardized procedure, like placing an overtube, requires paralyzing the patient just to relax one single muscle and ensure safe passage, what layer of planning, with sheer technical precision, must go into the truly cutting-edge, novel surgical technologies that haven't been standardized or refined yet?
It's another level entirely.
It really makes you appreciate the logistics of innovation in medicine, something to consider next time you encounter any kind of medical device.